Welcome to this high-stakes, high-yield explainer on hypertensive disorders of pregnancy. We are going to dive right in so you have the exact clinical judgment frameworks you need to absolutely crush the NGN NCLEX. I'm going to walk you through exactly what matters. Today, we're building a clear mental map. We'll cover the high-stakes basics, the domino effect of the pathophysiology, spotting danger signs, priority interventions, high-yield pharmacology, and finally, dodging those sneaky NCLEX test traps. All right, part one, the highest-stakes basics, why this matters, and what to look for. Look, this topic is a leading cause of maternal morbidity and mortality worldwide. For you as the nurse, early detection is quite literally a matter of life and death. The absolute most crucial point you've got to carry into your exam and your practice is this. While we can manage symptoms and prevent seizures, delivery is the only cure. Delivering the baby and placenta is the definitive treatment. Everything else is just buying time and stabilizing the patient until that happens. Let's lay down our foundational clinical definitions. Preeclampsia is new-onset hypertension. We're talking 140/90 or higher, plus proteinuria or end organ dysfunction after 20 weeks. But here's the kicker. Eclampsia is defined by the sudden onset of an obstetric emergency, specifically tonic-clonic seizures. Then we have HELLP syndrome, a severe variant featuring hemolysis, elevated liver enzymes, and low platelets. You need to know these three distinct profiles cold. Moving on to part two, pathophysiology, the domino effect, tracing the unbroken thread of the disease. To really anticipate what your patient needs, you've got to understand how this domino effect begins. It all starts in the placenta. Notice this unbroken chain? It kicks off with abnormal placental implantation. That leads to poor spiral artery remodeling, which essentially causes placental ischemia. The placenta gets starved of blood, right? That ischemia triggers widespread endothelial dysfunction, dropping your patient straight into dangerous systemic vasospasms and capillary leaks. Do not let the NCLEX trick you here. This is a widespread multi-organ vascular crisis, not just quote-unquote high blood pressure in pregnancy. That systemic vasospasm explains why symptoms escalate way beyond simple hypertension. It starts attacking the liver, the kidneys, and the brain. It's truly a whole body issue. Part 3, spotting the danger signs. Moving from mild to severe to crisis. As a nurse, your clinical judgment completely hinges on recognizing when a patient is crossing the line from mild to a life-threatening crisis. Check out how clearly this escalation is mapped out here. A bit of mild-dependent edema in the hands and face, that can snowball incredibly fast into devastating complications like placental abruption, stroke, or pulmonary edema if we aren't paying close attention. You are the frontline defense catching that shift. So here is your priority data. If you see any of these red features on a case study, anticipate immediate intervention. You report these fast. We're talking blood pressure hitting 160/110, severe persistent headaches, visual changes like seeing spots or blurred vision, right upper quadrant or epigastric pain, urine output dropping below 500 milliliters a day, bounding hyperreflexia and clonus, or platelets tanking below 100,000. These are your impending disaster signals. Let's zero in on HELLP syndrome for a second. Memorize this acronym and remember this massive clinical pearl for the NGN. Up to 20% of HELLP patients actually have totally normal blood pressure. Seriously. So if your pregnant patient has right upper quadrant pain, nausea, or just says they feel off, those are huge red flags, even if the BP cuff reads normal. Part 4, priority interventions and safety. ABCs and protecting the patient. All right, let's shift into action mode. What are your absolute priority nursing interventions to keep the patient safe? It's always ABCs and safety. That means creating a low stimulation environment with strict seizure precautions. Padded side rails up, quiet, dim room. You're going to constantly monitor those deep tendon reflexes and keep that continuous fetal heart monitor on. Also, a highly testable intervention, place the patient in the left lateral position. Why? Because it dramatically improves placental blood flow.
Now, if a tonic-clonic seizure actually occurs, stay with the patient. Prioritize their airway by turning their head to the side and monitor that oxygen saturation. And listen to me carefully. Never, ever apply restraints. It will cause injury. Protect the airway, sure, but do not restrain their body.
Part 5, high-yield exam pharmacology, knowing your meds and their jobs.
We're moving into the exact pharmacology decision rules you'll carry into the exam. And here is the ultimate test trap. Magnesium sulfate is strictly a central nervous system depressant for seizure prophylaxis. It is not a BP drug. Medications like labetalol and hydralazine, those are your actual antihypertensives to lower blood pressure. Do not mix these up. Mag is for seizures, labetalol is for pressure.
Anchor this number in your brain right now, 4 to 7. 4 to 7 milliequivalents per liter is the precise therapeutic range for magnesium sulfate infusion. Drop below 4 and you have zero anti-seizure effect. Climb above 7 and toxicity hits fast.
And speaking of toxicity, the very first sign is the loss of deep tendon reflexes. Just use the mnemonic: no reflexes, no breath, no pee. It starts with absent reflexes, progresses to a respiratory rate dropping below 12, and then urine output stalling below 30. If you see those reflexes disappear, your priority clinical judgment is to stop the infusion immediately and grab your antidote, calcium gluconate. Calcium saves the nerve.
Finally, Part 6, Dodging NCLEX test traps, common mistakes to avoid.
Let's rapid fire through the traps nursing students fall for most on the NGN. First, remember that seizure risk actually continues up to 6 weeks postpartum, which is why we keep the MAG running for 24 hours after delivery. Another massive trap: never give a preeclamptic patient methogen for a postpartum hemorrhage. Why? Because it will dangerously spike their blood pressure. You have to anticipate using oxytocin or carboprost instead. Let's test this. Your preeclamptic patient on magnesium sulfate suddenly shows absent deep tendon reflexes and a respiratory rate of 10. What's your very first priority clinical judgment? You stop the infusion, protect the airway, and get that calcium gluconate ready. But ask yourself this as you step into your exam and into your future practice. If delivery is the only true cure, how will you advocate for both the mother and the premature baby when the clock is ticking? Keep your clinical judgment sharp, remember what to assess and report first, and you won't just pass the NCLEX, you'll save lives.